Hi everyone, this is Dr. Karishni. Today we are going to talk about MCTD, Mixed Connective Tissue Disorder. So in the new RUCs, they have given two different terminologies. One is UCTD, which is undifferentiated CTD, and MCTD, which is Mixed Connective Tissue Disorder. So what is this UCTD? So anything which has its clinical, serological and pathological features of an autoimmune connective tissue disease for which a precise diagnostic classification is not possible. That means there are some features which are present in the diagnostic criteria, but it is not meeting the entire diagnostic criteria. So that time we will call the term as undifferentiated CTD. Now over time these patients, they develop new signs and new symptoms which they ultimately get fit into one of the diagnostic criteria of any of the traditional CTD, such as SLE or systemic sclerosis or even rheumatoid arthritis. Now coming to MCTD, it itself is considered as a distinct disease now with the presence of U1 RNP antibodies. So that the presence of this U1 RNP antibodies is what that differentiates UCTD versus MCTD for us now. Now coming to the epidemiology, UCTD is present in about 25% of the cases attending the rheumatology department, whereas MCTD usually the incidence is 1.9 per 1 lakh population with a delay of 3.6 years in diagnosis and with a female predominance. The average age is about 37.9 years. However, 1/4 of the cases had a juvenile onset of the MCTD. Coming to the pathophysiology, so there are two main factors. One is the genetics, other is the environmental factors. So genetics, we know some of the HLAs have the predisposition. So HLA DRB1, DRB4, DQA1, DQB1. So these. Now coming to the environmental factors, again in environment there are two main factors. So one is UV radiation, other one is vitamin D deficiency. Now whenever this MCTD is triggered by the UV radiation, the patient will usually have the clinical phenotype similar to that of systemic lupus erythematosus. So the next one is the vitamin D deficiency. Again we know because vitamin D is an immunomodulator, again it might trigger the formation of autoreactive B cells. So what happens here is that the UVB radiation, along with the presence of some autoreactive B and T cells, they will cause the formation of U1 RNP antibody. Now this U1 RNP antibody, it binds to the U1 RNP complex, particularly to the 70 kilodalton motif. So this will cause cellular apoptosis. Now apart from the genetic environmental factors, we also have some drug induced MCTD cases as well. Usually the drugs implicated are TNF alpha inhibitors, vinyl chloride and silica. Now what is the pathology, histopathology that we see usually in the blood vessels? So the most common usually clinical finding we find in MCTD patients is the Raynaud's phenomena. So in Raynaud's phenomena we find hypertrophy and proliferation of small and medium sized blood vessels. Now here we also find digital ulceration, that is because of increase in endostatin. So it is an inhibitor of angiogenesis, thereby causing digital ulceration. Now it is also considered as a marker. Now coming to the clinical features, so in undifferentiated CTD, it's basically where we are considering a traditional CTD, but the diagnostic criteria are not met. So usually they present with Raynaud's phenomenon in isolation, in which we find a positive serology. We find nail fold capillaries abnormalities as well, but it is not meeting the complete diagnostic criteria of systemic sclerosis. Or we find a variable rash, again with a positive serology, and with non-diagnostic feature, non-specific features of a particular CTD. And when we do the skin biopsy, we will find the vacuolar interface changes. Next, other things is, again we also find polyarthritis, but not meeting the diagnostic criteria of rheumatoid arthritis. Then immunological and serological abnormalities and multiple non-specific symptoms of inflammatory diathesis such as fatigue, myalgia, arthralgia. So all these non-specific symptoms will also be there. And what are the other cutaneous features, other non-specific features such as dermatitis, photosensitivity, urticaria, unexplained edema, psoriasis, non-specific red macule papule and patches. Now when we biopsy these lesions, we find interface changes, and also some of the lesions similar to annular erythemas have also been reported to occur in these conditions. Now coming to MCTD. Now MCTD is a specific disorder actually. So since it is a specific disorder, it has its own diagnostic criteria. So usually patients are initially diagnosed as a UCTD. Later they get diagnosed as MCTD or any other CTD. So what is the diagnostic criteria of MCTD? There are two diagnostic criteria. One is the Alarcon-Segovia's criteria, other one is the Kahn's criteria. So the Alarcon-Segovia's criteria, in which we in both of these diagnostic criteria, we have three important two important components. One is the serology, as well as the clinical features. So in both of them, the serology is the common one, in which we find anti-UNRNP antibodies, but the titers are different. So in the Alarcon-Segovia's criteria, the titer, it should be at least more than 1:1600 dilution, and in Kahn's criteria it is 1:1200 only. Now coming to the clinical features, in Alarcon's criteria we find swollen hands, synovitis, myositis, Raynaud's phenomenon, and acrosclerosis. So here in Kahn's criteria also we find, but not whole hands, swollen fingers, synovitis, myositis, Raynaud's phenomenon. Only sclerosis is not there. Now what is the diagnostic criteria? In Alarcon-Segovia's criteria, serology and at least 3 clinical signs, in which they must include myositis or synovitis. Whereas in Kahn's criteria, it is serology, Raynaud's phenomenon, and any 2 of the remaining clinical features. So we understand that mainly the focus is on Raynaud's phenomenon and myositis and synovitis. So we can understand how much we get confused, and somehow we can also misdiagnose, or we can overdiagnose it as systemic sclerosis as well. So other presentations, one is systemic sclerosis overlap, in which patient presents with Raynaud's phenomenon, edema and swelling of the hands, sclerodactyly, facial redness, calcinosis cutis, vasculitis of the digits, telangiectasia, livedoid vasculopathy, oral ulcers. So all these. Then subcutaneous and peritendinous nodules, dry eyes, dry mouth also. So one is a systemic sclerosis overlap, in which only Raynaud's phenomena, sclerodactyly, then calcinosis cutis will be present. And one is similar to SLE, in which oral ulcers, telangiectasia, livedoid vasculopathy can be present. And one is similar to Sika syndrome, in which dry eyes, dry mouth can be present. Then some other non-specific features can be atrophy blanchi, non-scarring alopecia also. In about 40% of the cases, they usually have a non-scarring alopecia with facial redness. Coming to the non-dermatologic clinical features, so they might also have arthritis, myositis, which are more common, and cardiac involvement in 13 to 65% of the cases. Then pulmonary involvement in the form of interstitial lung disease or pulmonary hypertension, GI dysmotility in about 50% of the cases, and renal disease, which is usually less severe than that of systemic sclerosis. Coming to the investigation, so what we want to do. So first and foremost, most important thing, a part of diagnostic criteria is UNRNP. So whenever we find UNRNP, if it is positive, so most likely is MCTD. 75 to 90% it is present in MCTD patients. However, in about 40% of SLE patients also UNRNP is positive. Now, in undifferentiated CTD, they have a constellation of antibodies being positive. They might be positive, might be negative. So many possibilities are there. Ultimately, the patient will land up into will fit into any one of the diagnostic criteria as well. So in this, we can see about in 22% of the cases RF factor is positive, 27% of the cases DSGN is positive. So in UCTD, we can find a range of antibodies. Coming to the dermatopathology part, what distinguishes, sometimes MCTD closely resembles systemic sclerosis, but based on our dermatopathology, histopathology, we can actually differentiate. The basement membrane staining with IgG or IgM is something which is present in MCTD and not present in systemic sclerosis. Coming to the prognosis, so as I told, undifferentiated CTD, 1/3 of the people eventually meet the criteria of a definitive CTD, and 10% of these people they might get a clinical remission, and they have the highest risk of progression in the first 2 years of life. And MCTD also has a good prognosis, except with the cardiac or pulmonary disease. So both the diseases have a good prognosis, but they do have a large impact on the quality of life because of the presence of arthritis and synovitis. They are more of a painful diseases with more impact on the quality of life. Now coming to the monitoring, so baseline and annually we will monitor, because there is chance of cardiac involvement or renal involvement or pulmonary involvement eventually. So we have to screen them with the help of for pulmonary function test, DLCO, and then transthoracic echocardiogram, then pro-BNP levels, urine analysis for the renal involvement, then regular blood pressure and ECG, and CPP, particularly for anemia and hypergammaglobulinemia. Now coming to the management. So mainly the first one is the lifestyle or general measures, then mainly the major component, the clinical feature, which is Raynaud's phenomena, and then obviously if it progresses into a more inflammatory disorder. So the lifestyle factors, we have smoking cessation, skin care and hand care, particularly for Raynaud's phenomena. Then after the like general measures for Raynaud's phenomenon, we can go for calcium channel blockers, phosphodiesterase inhibitors, prostacyclin analogs, endothelin receptor antagonists as well. And for the inflammatory disease, so like any other CTD, we can start with corticosteroids at the dose of 0.5 to 1 mg per kg. We can also add anti-malarials. We can also give methotrexate. We can also give rituximab for recalcitrant cases. So the detailed explanation of Raynaud's phenomena, the management of Raynaud's phenomena will be taken up in another video. So this is about MCTD, and the basic difference of MCTD and UCTD has been explained in this video.